Welcome back to Clinical History in English. Today's case, we'll be looking at a patient with diarrhoea. Notice the spelling of diarrhoea, especially in British English, there's a lot of extra letters. R-H-O-E-A. Right, so imagine you are working in a primary care medical centre and a 21-year-old male presents with diarrhoea. You take a history from the patient and record the following. Presenting complaint, diarrhoea. History of the presenting complaint. 3-week history of loose, watery motions. Motions. That is one of the words that we use in English to describe feces. Bowels opening, or BO, 3 times per day. So bowels opening is a common way that both doctors and patients describe defecation. Bowels is an old-fashioned word for intestines, so literally we're saying how many times did your intestines open, and that's where that phrase comes from. So it's a common one that we use. So his bowels are opening 3 times a day. He denies nausea and vomiting, but has had associated abdominal discomfort, bloating, that's a way of saying distension, bloating, and PR, or per rectum mucus. So PR is a common abbreviation that we use in medicine for per rectum. He denies PR bleeding. He denies fever or sweating. He has reduced appetite and he thinks he has lost 1 to 2 kilos in weight. He has had no recent travel and no unwell contacts. There is no past medical history of note and no relevant family history. So it has no family history of colon cancer, of inflammatory bowel disease, or irritable bowel syndrome. In terms of his drug history, he doesn't take any medication, but he does have a penicillin allergy, which results in a generalised maculopapular rash, so a generalised red, flat or slightly raised rash if he has penicillin. In terms of his social history, he's a shop manager, so that's important in the context of diarrhoea, that he's not working with a vulnerable population and he's not working with food, for example. He is independent in all his activities of daily living, or ADLs. He lives alone. He's a non-smoker. He's a social drinker of 2 to 4 pints of beer at the weekend, and he denies recreational drug use. So what is our differential diagnosis? Well, this could be an infectious cause. It could be a viral or bacterial infection. It could be inflammatory in origin, so inflammatory bowel disease such as Crohn's or ulcerative colitis. Or this could be irritable bowel syndrome, a functional bowel disorder. And even with his very young age, we need to always be aware of the possibility of malignancy, possibility of a cancer. So let's move on to examining our patient. In terms of the observations, his heart rate is normal at 80 beats per minute. His respiratory rate is also normal at 12 breaths per minute. And his blood pressure, or BP, is 105/73. His saturations, or SATs, are 98% on room air. So he is hemodynamically stable. On inspection, he appears well hydrated with no difficulty in breathing. And then examination of his pulse, it is regular, normal rhythm and volume. His heart sounds are 1 + 2 + 1 with no added sounds, so no murmurs. And moving on to examine his abdomen, it is soft. There is minimal generalised tenderness, so it's tender all over a little bit. There are no masses and no guarding or rebound. So those are 2 signs of peritonitis, so no signs of peritonitis. On digital rectal examination, or DRE, or the other way of saying that is per rectal examination, or PR examination, there is brown stools on the glove. Stools, that's another word for feces. So we've seen today the expression motions and stools to describe faeces. And there is no blood and no masses. So now we want to do some investigations, some tests. So we decide to request the following: a stool sample, so a faeces sample or stool sample for culture and sensitivity. That's how we can assess for infectious causes. We'd like to do as well a fecal calprotectin. So calprotectin levels are raised if there's inflammation in the gut or the gastrointestinal tract. And we'd also like to do some blood tests, including a full blood count or FBC. A full blood count includes red blood cells, white blood cells, and platelets. And we also want to look at inflammatory markers. So this will give us an idea if we're looking at irritable bowel syndrome, where all the tests should be normal, or if we're looking at a more significant pathology such as inflammatory bowel disease, malignancy, or infection. So let's look at the results. His hemoglobin is normal, so he's not anemic. His white cell count is just slightly raised. And if we look just down below, his neutrophil count is also slightly raised, so there's a neutrophilia. His platelets are normal. His erythrocyte sedimentation rate, or ESR, that's one of our inflammatory markers, is raised. And our C-reactive protein, or CRP, is also raised. So he's got raised inflammatory markers and a slightly raised white cell count, but no anemia. So looking at more of our test results, we've got a fecal calprotectin result where less than 50 is normal, 50 to 150 is equivocal, so neither positive nor negative. And then we have over 150 being abnormal. And his result has come back as 164. So there are signs of inflammation. And the stool or fecal microscopy culture and sensitivity has come back with a watery consistency on appearance and the presence of mucus and pus or leukocytes, no red blood cells, no erythrocytes, and no pathogens isolated. So from that, we can be fairly confident in ruling out an infectious pathology, but inflammation is still on our list, and certainly irritable bowel syndrome we've ruled out as well, because the test results should all be normal in a functional bowel disease. So I think our working diagnosis on pression is that of inflammatory bowel disease. Malignancy would be unlikely in this age group, but it still needs to be, we still need to be slightly suspicious of it. And therefore, in terms of our management, we need to refer him to a specialist, to secondary care, ideally to gastroenterology. There they are likely to do a colonoscopy to get more information, really, to form a solid diagnosis. And in the meantime, we want to give the patient what we call a safety net. So we advise the patient to return to see us if the frequency or quantity of the diarrhoea increases, and they're thinking about concerns of him becoming unstable, or if the patient develops a fever, perrectal bleeding, PR bleeding, or if the patient begins to feel otherwise unwell. So we want the patient to come back if they're beginning to feel unwell, in case one, we have the wrong diagnosis, or in case two, the diagnosis has the current situation has worsened and the patient might need more urgent care than just a secondary care referral. So thinking about whether a patient might need admission to hospital. Right, so that's the end of the case, and I've just added a couple of slides for interest. This is the Bristol stool chart. It was developed in Bristol Royal Infirmary in 1997 in the UK, and we use this chart to help both healthcare professionals and patients characterise the motions they're having. So type 1, small hard pellet type poos, similar to what a sheep or a rabbit might produce, and then type 7, pure liquid diarrhoea. So this can be really helpful to objectively define what's happening with the faeces. And as we doctors have a bit of a strange and dark sense of humour, From this stool chart has come lots of merchandise. So if you're interested, you can get yourself a t-shirt, a mug, or a pillow with the Bristol stool chart, and there you can see Bristol whereabouts it is in the UK. And there are some talented and slightly interesting medical professionals who've even gone as far as making cakes with the Bristol stool chart. I'm not sure if I'd be tempted to eat one, each to their own. Okay, so let's review a couple of the words and vocabulary that I think were important in today's case. So we have the word diarrhea. So when you say this word, don't look at the letters, just listen to how it sounds, diarrhea. And then for spelling it, well, good luck. All of us native speakers have had to learn this just by learning, and I think it's the same for everybody. It makes little sense, but that's how it is. And that kind of ending, the rhea, is a word we see a lot in medicine, isn't it? For example, rhinorrhea, diarrhea. So it's worth learning that ending. And then we have the words stools and motions, both of which are ways of saying feces, or poo would be the very informal way of saying it. And bowels opening, meaning doing a number 2, defecating, bowels opening. And then we had the word bloating, which is a way of saying distension, bloating. And let's look at some of the abbreviations. So we had PR, per rectum, so PR bleeding, PR examination. We had DRE, digital rectal examination. The next two are difficult to remember because they're almost the same except for one letter. But we have irritable bowel syndrome. So it's the irritable and it's the syndrome, it's the functional bowel disease. And then we have IBD, which is the inflammatory bowel disease. And then we had some investigations, some tests that have abbreviations. So FBC, do you remember what that one stood for? Full blood count. CRP, C-reactive protein, and ESR, erythrocyte sedimentation rate. So the last two were our inflammatory markers. And that's it for today. Hopefully that was helpful. If you enjoyed it, please give us a like. Feel free to write a comment with suggestions or questions. And feel free to follow us as well at Clinical History on Facebook and Instagram. All right, take care. Bye.